cavity between the visceral and the parietal pleura, and it's a negative pressure. Transpulmonary pressure is the pressure gradient between the alveoli and the pleura. It is always a positive pressure, and it is the pressure which is required to maintain the alveolar inflation. Pressure is the pressure gradient between the pleura and the atmosphere, and it is the pressure that is required to expand and contract the lungs and the chest wall at the same time, which acts together as a single unit. Trans-airway pressure is the pressure gradient between the air opening and the alveolar pressure, which creates a gradient for gas flow into the lungs. So this is an image showing the respiratory mechanics. As we discussed above, during at rest, normally the alveolar pressure is same as that of the atmospheric pressure, that is 0. During inspiration, spontaneous breathing, as we all know, it's a negative pressure process. So the alveolar pressure reduces than the atmospheric pressure, creating a pressure gradient between the atmosphere and the lungs, which pushes the air from atmosphere into the lungs. At the end of the inspiration, the alveolar pressure increases and goes up to +1 centimeter of water, again creating a pressure gradient, pushing the air out of the lungs. So this is a table showing the pressure changes during inspiration and expiration. Next, let's discuss the indications for mechanical ventilation. So whenever a person is not able to maintain the spontaneous breathing process, which could be due to some pulmonary pathologies or non-pulmonary causes, we use certain physical devices or machines to either replace or assist the spontaneous breathing process of the patient. So this is called as mechanical ventilation. So the various indications for mechanical ventilation are given in this table. First is the depressed respiratory drive, which could be due to various causes such as drug overdose, spinal cord injury, head trauma, neurological dysfunction, sleep disorders, metabolic alkalosis, where there is compensatory hypoventilation to maintain the pH. Next is hypoxemic type 1 respiratory failure, which could be due to acute lung injury, acute respiratory distress syndrome, pulmonary edema, pulmonary embolism, pneumothorax, infections, carbon monoxide poisoning, and chronic conditions leading to type 1 respiratory failure, such as the interstitial lung disease and congestive heart failure. Next is type 2 respiratory failure, and the causes for type 2 respiratory failure are COPD or acute exacerbation of COPD, head and neck injury, neuromuscular disorders, obesity, hypoventilation syndrome. Prophylactic ventilatory support is provided in conditions when there is anticipated oxygenation or ventilatory failure or suspected pulmonary complications, as in prolonged shock, head injury, smoke inhalational injury, hypoxia, or in major surgeries such as coronary artery bypass surgery, thoracic or abdominal surgeries to reduce the cardiopulmonary stress. Relief of upper airway obstruction, as in anaphylaxis, soft tissue infections of the neck, head and neck trauma. Types of ventilation. So there are two types of ventilation depending on the pressure gradient that is developed, that is positive and negative pressure ventilation. In negative pressure ventilation, the intrathoracic pressure is negative, which creates a pressure gradient and pushes the air into the lungs. Whereas in positive pressure ventilation, intrathoracic pressure becomes positive. So this is an image showing the iron lung device and the chest shell, which are all the devices used for negative pressure ventilation. Before this, the intrathoracic was negative, which created the pressure gradient and helped in respiration process. But with the advent of positive pressure mechanical devices, these devices are no longer. Next, depending on the driving mechanism for inspiration expiration, there are two devices which can be used, that is the bellows and the piston mechanism. So bellows is an accordion-like device which is actually of two types, that is ascending and the descending type, based on its attachment to the bellows assembly circuit. Ascending type is also called as the upright, standing or floating type. Descending type is also called as the hanging or inverted type. The bellows circuit is covered by an housing unit, which is made up of a transparent plastic cylinder, which helps in visualization of the bellows during its movement during inspiration and expiration. The mechanism on which it works is given in this diagram. So there is a driving gas flow in the bellows assembly, which enters into the bellows assembly and increases the pressure within the assembly. Because of this increased pressure, there is compression of this bellows, which pushes the respiratory gas into the breathing system and it's delivered to the patient. At the end of the inspiration, the exhaust valve is open, from which the driving gas is pushed out, which in turn reduces the pressure inside the chamber, and the bellows unit goes back to its original shape. Apart from the exhaust valve, there are also two other valves which are present in the bellows system, that is the safety relief valve and the spill valve. Next is the piston system, which is an electrically driven system. It does not have any bellows or bellows housing. It does not require any driving gas. Piston system is of two types, that is the rotatory and the linear driven system. So as given in the A image, which is a rotatory system, the backward stroke of this piston system opens the first one-way valve, which pushes the respiratory gases into the assembly. And the opposite stroke of the rotatory piston system opens the second one-way valve, via which the respiratory gases are pushed into the breathing circuit and is delivered to the patient. Because it's an electrically driven system and there is no driving gas flow in this, the airflow to the patient is more stable in the piston system. Next, it is important for us to know the basic ventilatory parameters which we have to see in the ventilator. First is the tidal volume, which is the volume of air that is moving in and out of the lungs during quiet breathing. The normal value is 6 to 8 ml per kg. This is an image showing the normal lung volumes in the capacities. The other basic ventilatory parameters are respiratory rate, inspiratory time, peak inspiratory pressure, positive end expiratory pressure, plateau pressure, flow, and FiO2, which is fraction of inspired oxygen, which will be discussed below. So this is a graph showing pressure versus time. Time is plotted in the x-axis and pressure is plotted in the y-axis. So as we can see, as the inspiration begins and gas flow into the airways, the pressure gradually starts increasing and goes to a peak value at the end of the lung inflation, which is called as the peak inspiratory pressure. This peak inspiratory pressure is the pressure which is required to overcome the resistance to airflow in the airways and the elastic resistance which is provided by the lungs and the chest wall. From this peak inspiratory pressure, the resistance to the airflow can be eliminated by occluding the circuit, which will stop the airflow. So this is done with the help of the inflation pole maneuver, where the expiratory circuit is occluded at the end of the inspiration. So the peak pressure starts falling initially and goes to a plateau value, which gives the plateau pressure. Plateau pressure gives an idea about the elastic resistance of the lung and chest wall, excluding the resistance to the airflow. This graph also gives us an idea about the inspiratory and the expiratory time, the total time that is required for a breath, and the inspiratory to expiratory ratio. So this is an image showing the same, this with inspiration, expiration, and inspiratory pause. This graph from the inspiration and expiratory values, it also gives us an idea about the compliance of the resistance of the airways. So compliance is nothing but the change in volume with change in pressure. And resistance is the resistance again which the air flows into the lungs, which is given by the formula pressure change by inspiratory flow. The other parameters which are seen in the ventilator are respiratory rate, which is the number of breaths per minute that is delivered to the patient. Next is the breath cycle time. It is the time taken for a breath cycle to complete. For example, if we are setting the rate as 12 per minute, the breath cycle time is calculated as 60, which is the total seconds per minute divided by the respiratory rate, which will give the value of a single breath duration. From this single breath duration, we have to calculate the inspiratory and the expiratory time, from which we will know the IE ratio. The normal IE ratio is 1:2. Next is the flow, which is the amount of volume that is delivered over time. How a ventilator delivers a breath. To know this, we have to know these 4 phase variables, which helps to begin, sustain, and end each breath. The 4 phase variables are the trigger variable, limit variable, cycle variable, and the baseline variable. First is the trigger variable. So trigger variable is the one which initiates the inspiration. This can be either machine triggered or patient triggered. In machine triggered, it is the time which plays an important role. For example, if we are setting a respiratory rate of 12 per minute in the ventilator. So the breath cycle time is calculated as 60 by 12, which will give us 5 seconds. So the machine delivers a breath at the end of each 5 seconds to the patient. Next is patient triggered, which is dependent on the volume, pressure, and flow. So when the patient has spontaneous efforts, the machine senses the changes in the volume and the pressure changes, which becomes negative during spontaneous effort, and the change in flow, and delivers breath to the patient. Next is the cycle variable. So in cycle variable, next is the limit variable. Limit variable limits the parameters such as volume, pressure, flow, and time of the inspiration. But it does not end the inspiration. And whenever the set parameters are attained by the machine, it just limits that particular parameter and the breath continues to be delivered by the machine. Next is the cycle variable. So as the name suggests, this is the variable which cycles from inspiration to expiration. That is, it ends the inspiration and begins the expiration, which is again dependent on volume, pressure, flow, and time. Next is the baseline variable. Baseline variable is gives an idea about the expiratory baseline before the next breath is triggered. Different types of graphs can be visualized on the mechanical ventilator, which can be scalar graphs or loops. So scalar graphs are one in which a particular variable is plotted against time, such as flow versus time, volume versus time, or pressure versus time. Loops are one in which two variables are plotted against each other, such as volume versus flow curves or pressure versus flow curves. So this is a graph showing flow versus time, in which time is plotted against the x-axis and flow in the y-axis, in which inspiratory and expiratory phase and the inspiratory and expiratory duration can be assessed. This is a volume versus time graph where the total volume is delivered over time can be assessed. Next is a pressure versus time graph, which shows the various variables, which will reduce the venous return to the right side of the heart. So there is a reduced blood that is entering into the right atrium, right ventricle, and the blood that is entering into the pulmonary circulation. So as a result, there is increased systemic blood volume, but the pulmonary blood volume is reduced.
Net, just to check her, the voice is not coming, whether her internet is unstable.
And the filling pressures and filling volumes.
Net. Dr. Sri, you are not audible.
I have called, sir. There's some internet problem. They're reconnecting, sir.
Am I audible now, sir?
Yes. No, there is some connectivity issue.
Please start with the systemic effects, please.
Okay, sir. Am I audible now, sir?
Yes, yes.
So the systemic effects of positive pressure ventilation. So let's start with the cardiovascular system. So when positive pressure ventilation is given to the patient, there is increase in the intrathoracic pressure, which compresses the vessels and reduces the venous return to the right side of the heart. So there is decreased blood that is entering into the right atrium, right ventricle, and reduced blood enters into the pulmonary circulation. As a result of which, there is increased blood in the systemic circulation and decreased blood in the pulmonary circulation. So there is a reduced filling of the left ventricle, which ultimately reduces the left ventricular stroke volume. Next is the pressure and cardiac output changes with positive end expiratory pressure. Positive end expiratory pressure compresses the pulmonary artery, which increases the pulmonary artery pressure, and this pressure is transmitted to the right side of the heart, which reduces the venous return to the right side of the heart and increases the central venous pressure. So again, there is reduced filling of the left side of the heart, decreased left ventricular filling, which reduces the cardiac output. So as we discussed above, because there is reduced cardiac output because of this positive pressure ventilation, perfusion to the vital organs such as kidney, liver, and gastrointestinal tract might be compromised. So in the renal system, when there is reduced cardiac output, there is decreased perfusion of the kidneys, renal hypoperfusion, which results in reduced GFR and reduced urine output. If this hypoperfusion persists over time, it might result in renal failure. In liver, reduced hepatic blood flow results in hepatic dysfunction. In the gastrointestinal system, because of this reduced gastrointestinal system perfusion and the medications that are used during mechanical ventilation, it might result in complications such as erosive esophagitis, stress-related mucosal damage, diarrhea, constipation, high gastric residual volume, and decreased bowel sounds. Another important concern in the gastrointestinal system is giving this positive pressure ventilation or positive end expiratory pressure to patients with increased intra-abdominal pressure. When positive pressure ventilation is given to patients with increased intra-abdominal pressure, the overall pressure is increased so much that it further reduces the cardiac output and it might compress the lung, reduces the functional residual capacity of the patient. Thank you.
With the permission of the moderator, thank you, Dr. Sri. And now I request our President, Dr. Munian, to give the presidential remarks. Dr. Sri, you can stop screen sharing.
Okay, sir.
Sir, good evening, sir. It's my honor to welcome you all for the ISA Puthukkottai City branch conducted online weekly webinar in the name of Puthukkottai Bhudhan. It is a 50th episode of second edition. Last webinar, there are 590 delegates who participated in our online weekly webinar. Today, our topic name is Basics of Mechanical Ventilation. Dr. Sreelakshmi delivered a good lecture on the basics of introduction of mechanical ventilation and the indication of the systemic effects relating to the mechanical ventilation. Welcome, Dr. Dr.Anshu Gupta, Professor, Department of Anesthesiology, Lady Hardinge Medical College, New Delhi, will speak on the weaning from ventilation. What are the criteria available for weaning will be delivered by Dr. Anshu Gupta. Welcome, madam. And Dr. Nishant Kumar, Professor, Department of Anesthesiology, Lady Hardinge Medical College, will speak on the basic mode of ventilation. Sir will deliver a good lecture on the mode of ventilation. Our association represents collective voice of specialty dedicated to promoting to the highest standard of anesthesia care, education, and research. So, our academic chairman, Dr. Meenakshi decided to put to participate in PG in the academic activity conducted by online weekly webinar in the name of Puthukkottai Bhudhan by ISA Tamil Nadu, Puthukkottai City branch. As anesthesiologists, we play a vital role in ensuring the safety of anesthesia and well-being of our patients during surgery and other medical procedures. Our association is committed for supporting our members in the pursuit of excellence through CME and advocacy and community building, like our online Puthukkottai Bhudhan webinar program. Today, we gather actively participate in the online weekly webinar conducted by Puthukkottai Bhudhan. Welcome, madam, and we'll listen the weekly webinar. Thank you, madam. Thank you, sir.
Dr. Kannan, Secretary, will present the report.
Good evening all. I am Dr. Kannan, Secretary ISA Puthukkottai branch. And we ISA Puthukkottai successfully conducting the 5th webinar of Puthukkottai Bhudhan. Today our topic is mechanical ventilation. And our speakers, Dr. Sreelakshmi, postgraduate, clearly explained the introduction to mechanical ventilation indications and systemic effects, and basic notes of ventilation, graphics and AC planning by Dr. Nishant Kumar, Professor, Department of Anesthesiology, Lady Hardinge Medical College and Associated Hospitals. And we welcome Madam Dr. Anshu Gupta, topic by weaning from ventilation, is our Professor, Department of Anesthesiology, Lady Hardinge Medical College. And we welcome our Madam Dr. Ranju Singh, Director, Professor and Head HOD, Department of Anesthesiology and Critical Care, Lady Hardinge Medical College and Hospital. We have done our fourth webinar on 12th February 2025. Our topic was management of difficult airway. Last topic, a very good topic, and securing surgical airway, clearly explained by our Professor, Department of Anesthesiology, Dr. Jayarani Madam, and difficult airway guidelines by Dr. Jayasatya, Assistant Professor, Department of Anesthesiology, Tanjavur Medical College, and Malambati classification by postgraduate Dr. S. Raghuraman, and our moderator was Dr. S.B. Gangadhar, Professor and HOD, Siddhartha Medical College, Karnataka. Last session was very nice, and some more problems. Last webinar attended by, even though some connectivity problem, 590 people attended the last session, and our academic chairman in last session, our academic chairman Dr. Meenakshi sir escalated the connectivity problem to the highest level CEO of Clarinet. Immediately they cleared, and they have given our separate platform for our programs. We thank very much. Thank you very much, sir. And we are very thankful to our academic chairman. And one more thing, we ISA Puthukkottai planning to conduct an ISA sponsored CME in Puthukkottai and upcoming May month. We wish to encourage our ISA Puthukkottai members, and thank you, sir.
Thank you, Dr. Kannan. So at this juncture, I thank the Clarinet CEO and the entire team for having taken up the matter and war footing. And even now I have checked, I have received no message regarding the connectivity problem. Suddenly one message came, sir, I am not logging in today because of another meeting. So it is not a connectivity problem. She has another meeting. So today I'm happy whether there is no connectivity problem or we have given a helpline numbers. Whether the message reached them, I don't know. But today I'm free. I thank the Clarinet for the active steps they have taken. Now it is over to the moderator, Dr. Ranju Singh Madam, to call upon Nishant.
Thank you so much, sir. Sreelakshmi has already explained the basics of mechanical ventilation. She's done such a good job at it. We will wait for any questions later.
At the end.
Yes. Now I invite Dr. Nishant. Meenakshi sir has already introduced Dr. Nishant so beautifully. He's a wonderful orator, and I'm sure he's going to present the relevant parts of mechanical ventilation beautifully in a simulated manner. And I present to you, Dr. Nishant. Over to you, please, for your start of the session.
Thank you so much, ma'am. And I would like to especially thank Dr. Meenakshi Sundaram and ISA Puthukkottai for this opportunity. Now, I don't have a PPT for the first part. Now, what you can see here, this is my, if you can see here, you can see the patient which I'm going to present here. Now, this is the ventilator screen, which is showing you the patient, an adult male with 173 centimeters height, 66 kgs ideal body weight, with normal lungs. The resistance is okay, compliance is okay, metabolism okay, and the patient is not breathing. So here we come to the ventilator. Now, Dr. Sreelakshmi has beautifully explained how the normal and the positive pressure breath differs. So basically, when we take a normal breath, what happens is that the diaphragm goes down. There's a negative pressure inside the thorax, and therefore the air from the atmosphere enters the lungs because of the pressure gradient. Now, going by the same phenomena, the flow is always against due to a pressure gradient. Now, this is because of a negative pressure created inside the thorax. What we can have is, we can have a different strategy wherein we push in air into the lungs. So that is the positive pressure ventilation, which we use nowadays for all modes. Now, the iron lung which she described was used during the polio epidemic. And after that, we had these COPD problems and everything, and they found that iron lung was not that very good in obstructive diseases. So we came up with the positive pressure. Now, I'll be explaining very simply the three basic modes of ventilation, that is the volume control mode and the pressure control mode, or the control mode where the patient is not breathing at all. Then when the patient is breathing, but the efforts are not adequate, or the mode which is most commonly used in weaning, that is the pressure support mode. And when the patient is somewhat breathing, but the efforts are not good enough to sustain ventilation, and some controlled breaths are also required, that is the synchronized intermittent mechanical ventilation, or the SIMV mode. Now, since our patient was not breathing at all, the patient was absolutely passive. So what we select is, the first thing is, we have to select the appropriate mode. Like in OTs, we paralyze the patient. So the patient is not breathing at all. So the mode that we have to select is the CMV, or controlled mechanical ventilation. Now these can be volume controlled or a pressure control. What is volume control? What is pressure control? I'll come to it a bit later. Now imagine when we talk of normal ventilation, there are a few things which govern us. Number one is the FiO2, that is the percent of oxygen that we are breathing. In Delhi, we say we are breathing 21%, but you all know, given the pollution of Delhi, God knows how much FiO2 is actually going in. So could be 15%, could be 16%, could be 20%, we don't know, depending on the pollution. High altitudes, we know that the FiO2 is low. Ladakh, it's around 16 to 18%. So the amount, the percentage of oxygen that is present in the atmosphere. Number two is the amount of volume that we take in, that is the tidal volume, as Dr. Sreelakshmi explained. Number three is the rate at which we breathe, that is the respiratory rate, and the time. Now, normally the time is controlled by us only, by the brain, so we don't realize it. But when we set the ventilator, we have to set all these things in the parameters. So the first thing is, now as I said, positive pressure means that we have to deliver a positive breath to the patient. Now this can be done in two ways. Either the ventilator can decide how much volume to deliver, that is, we have a set volume to deliver, and it is controlled by the ventilator. All the breaths are controlled by the ventilator, so it becomes a volume control mechanical ventilation. The other thing is, instead of volume, we tell the ventilator, you don't deliver a particular volume, but you drive in air with a particular pressure, a set pressure. You just push in air with a set pressure. You create a pressure gradient, and whatever air goes in is acceptable. So since we are controlling the pressure, that becomes a pressure control mode. Now, first we'll talk about the volume control mode. So you can see here, this is the CMV, or the volume control ventilation. So this is based on this. Here we go. Now, again, what are the settings that we have to set? The first thing is FiO2. That will depend on the ABG, or the saturation of the patient. Now, since this is a simulation, let's keep it at 50%. Number one. Number two, we have to tell the ventilator how much volume to deliver. Now, this has been calculated as 8 ml per kg by the ventilator itself. Remember, our patient was 66 kg, so it is 530 ml. Third thing we have to set is what rate that we want to set for the patient. At what frequency the breath is to be delivered by the ventilator is defined by the rate. So the normal is 10 to 12 breaths per minute. So that is absolutely fine. It is 12 breaths per minute. Then is the inspiratory time. As Dr. Sreelakshmi explained, now we have to tell the ventilator how long should be the inspiration, how long should be the expiration. Now, if we see here, with a rate of 12 and an inspiratory time of setting of 1, I'm getting an I ratio of 1:4. Now, for normal lungs, we all know that we can keep an I ratio of 1:2, which is normal, absolutely normal. So I have increased the inspiratory time so as to get an I ratio of 1:2 with an expiratory time of 3.35 seconds and an inspiratory time of 1.65 seconds. Now you have to be careful here. What one major mistake people make is that when we have set the ventilator and we change the rate. Now, suppose I change the rate to 14 or 16 or say 18 to wash out carbon dioxide. Now, what has happened? I have changed the rate, but I have not changed the inspiratory time. So my IE ratio, which was 1:2, has now suddenly reduced to 1:1. So please be careful whenever you're changing the rate. Please take a look at the IE ratio, because that will be changed because you have kept the the inspiratory time constant. Now coming to the simple mode, that is our volume control mode, giving 530 ml at the rate of 12 breaths per minute with a PEEP of 5. Now PEEP is simply the end expiratory pressure. That means that is the amount of pressure that remains in the alveoli to keep them open so that they don't collapse at all. Okay, so now this is our, I'll just speed it up just for this thing. So now as you can see, what we have told the ventilator is that the ventilator is supposed to deliver 530 ml with a rate of 12 breaths per minute with 50% FiO2 and with an I ratio of 1:2. Again, one thing we have to set is the trigger, flow trigger or pressure trigger. That means that the ventilator will sense a change of flow or pressure so that it will come to know that the patient is trying to breathe. Now, for normal lungs and normal patients, we keep normally a flow trigger of 3 liters per minute or a pressure trigger of 2 centimeters of water. That means that if the patient initiates or generates a pressure of 2 centimeters of water, the ventilator will know that the patient is trying to take a breath. Now, please remember that the pure volume control mode is now almost obsolete in the modern ventilator. What we have is something called as the assist control ventilation, which I'll be discussing in a minute. Now, coming to this, okay, so I've kept it as a flow trigger. And if you can see here, this is the pressure time graph. Flow pattern is, yeah. So we have set the flow, the pressure wave, and this is the flow time. So this is the inspiration, this is the expiration, this is the flow versus time. And as you can see, we have to see that the expiration reaches the baseline. That means that there is complete emptying of the alveoli and there is no volume trapping as occurs in COPD. Now, if you see here, pressure time graph, the pressure is on the y-axis, time is on the x-axis. So the pressure rises, maintains at a particular level and then comes down, and see, it is not touching the baseline. So the pressure at the end of expiration which is occurring is called as PEEP. So we have the monitors here. We have the P peak, as Dr. Sreelakshmi explained. This is the peak inspiratory pressure, the total minute volume, the tidal volume that we have that is being expired. Now it is very important to monitor the expired tidal volume. You can see here it is written as VTE. So this is the expired tidal volume. Now we have set the tidal volume as 530. These are the set parameters, and this is what the patient is getting. Now, it is very important to see the VTE, because if there are leaks, if there is obstruction, if there is volume trapping, or if there are patient efforts, this will vary. Now, this won't be 530. If there is leak, you'll immediately come to know, because this will come down. And remember, whenever you are setting your parameters, you have to set the alarms as well. Now we have to set the pressure alarm. Now, if we have set it at 40, now this is the limit that we are setting, that we are not allowing the pressure to go beyond 40. We have told that the ventilator has to deliver a tidal volume of 530 with a rate of 12. Now, if the compliance is poor, naturally it will require more pressure to give 530 ml. Now, it is going for 17, but if the lungs are bad, you may require a higher pressure to deliver this 530 ml. Ventilator says, I was told to deliver 530. I was not told anything about the pressure. So that is why it is very important that you set safe limits for pressure, because the constant variable here is volume. but the pressure will depend on the compliance and the condition of the lung. This is the expiratory minute volume, low and high. If there is a disconnection, naturally there will be a leak. The volume will, the minute volume will decrease and it should give us an alarm. Or if there's any other problem, then rate, if the patient is breathing in on his or her own, or if there's a ventilation disconnection, again, we should set the high and the low limit. Remember, these are set to the patient's condition, high and low tidal volume, and for how long the apnea time is there. Now, this ventilator usually has an EtCO2 connected also, so we can set the limits of end-tidal carbon dioxide as well. So this is very simply a volume control mode where the patient is not taking any breath and the entire breaths are given by the ventilator. Now, coming to the other thing. Now, what we do is we change the mode. Now, this is the volume control mode. Now we come to the pressure control mode. So I've just selected pressure controlled. That's it. And I confirm it. Now in pressure control mode, we set the FiO2. Again, we set the trigger. Trigger is what will initiate the breath. The ventilator will know when the patient is trying to take a breath. The PEEP, that is the end expiratory pressure. The rate, as said before. Then the pressure control. That is the amount of the pressure that the ventilator has to give. So we keep it as for normal lungs, 15 is good enough. Now remember, here we are telling the ventilator that you have to deliver air or mixture of oxygen and air with a pressure of 15 centimeters of water. Now again, the amount of volume that the patient will get will depend on the lung condition. So here the control variable is pressure and the variable is volume. So remember, in volume control, you have to monitor the pressure because pressure will keep on changing, and in pressure control, you have to monitor the volume because volume will keep on changing. Ramp is how fast the pressure should rise. So in how much time we should achieve a 15 centimeters of water pressure. So normally we set it at 200. Again, this will depend on the patient condition. So I confirm it and I start the ventilation. Now, if you can see here, the pressure rises, maintains, and then comes down. Now you can see here with a pressure of 15, the ventilator is giving alarm. The high ventilation alarm and the tidal volume is going up to 850. So now the patient is exactly the same. Peak pressure is going up to 20. Why? Because we have added a PEEP also. So the ventilator is developing this pressure control that we said. The peak inspiratory pressure is over and above the PEEP. So remember, if you see 530 ml was being delivered with 17 centimeters of water. So now I reduce it. Let us see what happens. Now, as you see, as I reduce the pressure, the tidal volume is reducing. Now let us see at what level it settles down. Now, since the lungs are normal, with a pressure control mode, I can deliver the same tidal volume with lesser pressures. So in conditions where you are having a high pressure with the volume control, you can switch over to pressure control. Now, some people say pressure control is better for COPD or asthma. This mode is better for this condition. It is not so. You should be able to manipulate and understand what are the mechanics of the patient and accordingly use the mode. So as you can see, so if you can see here, I can further come down on the pressure. The compliance and all is pretty good. So with this, even 13 centimeters of water, I can achieve almost the same tidal volume, right? And EtCO2 will also come into the place. So all you have to do is monitor the graphics. Why? Because these graphics are important. Any upstroke or this thing, you need not monitor this. Just by looking at the graphs, you'll come to know whether there's a leak, whether there's a volume trapping, whether there's adequate flow or not, whether there's any obstruction. You can see this nice white square rectangles which are there. So if there's any obstruction, this will be contracted and the height will increase. So this is about the control modes. Now let us say that the patient is breathing spontaneously. So let's go to our patient and make him breathe actively. Okay, so the patient is taking his or her own breaths, but what is happening is that the efforts are not okay. Now, when we talk of pressure support mode or the spontaneous mode, the terminologies may be different for different ventilators. Now, the thing here is that, again, you have to set the FiO2, the PEEP, and by how much pressures the patient's breaths are to be supported and the RAM. So these are the basic things that you set. The IE time will be set by the patient because the patient is breathing spontaneously. So I put the patient on spontaneous breaths and let us see what happens. So here you can see now with a pressure support of 8, the patient is achieving a tidal volume of, it's increasing in fact. So that means that we are giving a bit too much of pressures. So we do not want this much of a tidal volume. So I come down on pressure. So the patient does not need this much of support. Now, again, remember this pressure support is over and above that of PEEP. Now, in controlled ventilation, what happens is if the patient is taking their own breaths, there will be a slight downslide here in the flow time graph, which indicates that the patient is trying to take a breath. There will be a slight notch here, which is not being shown in the simulation. Similarly, there will be a slight negative pressure, which indicates that the patient is trying to take a breath. Now here, what is happening is the patient is breathing spontaneously at his or her own rate. Depending on the tidal volume, we know that as the tidal volume goes down, the rate increases. And as the tidal volume goes up, the rate reduces, because ultimately the aim is to maintain a minute volume to expel carbon dioxide. So this is a purely spontaneous mode where the ventilator is just helping the patient. It's just like you're cycling, you're tired, and you ask your friend to push to get a more speed. So that is what the ventilator is doing, and this is purely a spontaneous mode. Then we come to SIMP. Okay. So this says this is a simulation, so I'll have to go to the patient again. Now in this, the patient is, now if you see here, remember, whenever you're setting up spontaneous mode, please set a backup mode. Now, if you remember, I made the patient passive. So the patient has stopped breathing. So the backup mode here set is APV-SIMV, which is PRVC, pressure regulated volume control. It is an advanced mode. And the ventilator is showing apnea ventilation. Now for 20 seconds, the ventilator senses that the patient has stopped breathing. Now, if you don't attend to it, the patient will expire naturally. So there's a backup mode, and if there is no waveform, the ventilator will automatically switch to the backup mode with the set parameters that you have set. So please remember that you have to set a backup mode whenever you put the patient on spontaneous mode. Otherwise, if there's a disconnection or the patient stops breathing, your patient is gone. Now coming to SIMV. Now SIMV can again be a volume controlled or pressure controlled. We'll just see the volume control mode here. Now in this, we set, this is a combination of pressure support and volume control, or the control mode. So we set the FiO2, we set the PEEP, we set the tidal volume for the control breaths, the rate for the control breaths, the inspiratory time and the I ratio for the control breaths, and the support. Suppose the patient takes his or her own breath. Now we know that the patient's effort is not good enough. So the patient breath has to be supported. Now the patient can take only generate 100 ml of breath. Now we know that that is not sufficient. We need to give 500 ml of tidal volume. So we set a support that in case the ventilator senses that patient requires a breath, it will support with a particular pressure and add on to the patient's effort and make up for that tidal volume. And for that, we set the RAM also. Now, what happens is in SIMV is that what we have set is that the ventilator is supposed to give 12 breaths, right? So the ventilator is supposed to get 12 breaths. I'll just pause it here. Now, if you see here, this is the inspirator inspiration. This is the inspiratory time here, and then changeover from inspiration to expiration, and expiration. This is the expiration here. This is the changeover from inspiration to expiration, and changeover from expiration to inspiration. Now, this is the expiratory time. In this, there is a window which is decided by the ventilator. Now, the ventilator is, I'll just reduce the rate to 10 for the sake of calculations. Now, we know that each breath is 6 seconds with an I ratio of 1:2. So, the inspiratory time is 2 seconds and the expiratory time is 4 seconds. Now, in SIMV, what happens is that there's a window here. In this 4-second period, say the ventilator keeps it a 1-second window here. Now, this 1-second window is that the ventilator says, I have to give my breath every 6 seconds. Now, I'll just give a leeway of 1 second. Now, if a patient is trying to take a breath here at the 5th second, instead of giving my controlled breath here, I'll give it when the patient is trying to take a breath and synchronize it with the patient's breath. That is why it is called synchronized intermittent mechanical ventilation. So the ventilator waits for it and will deliver a breath earlier if the patient is trying to take a breath. Now, the older ventilators had a plain SIMV mode. That means that there was no pressure support added to it. Nowadays, the ventilators have SIMV plus pressure support. Why this pressure support? Suppose the patient doesn't generate the breath in this window period. If it is generating the breath in this window period, the ventilator will synchronize and give the breath earlier. But suppose the patient generates a breath here and the patient's efforts are not good enough. What will happen? Now, if the patient generates a breath here and takes a breath, say 50 ml or 100 ml, you'll see a very small deflection which says that the patient is trying to take a breath. Now, that will be inadequate and the patient will hyperventilate. So, when we add pressure support here, that will act like a spontaneous mode. The ventilator senses that the patient has taken a breath and will support with the pressure that we have given. So, that is why SIMV is never kept alone and we always give SIMV with pressure support. Now, what do you mean by volume SIMV and what do you mean by pressure SIMV? Remember, the spontaneous breaths of the patients are always pressure supported. Now, the controlled breaths which the ventilator is giving can be either volume controlled or pressure controlled. The same way the parent mode was there. So, in volume control, the pressure will change. In pressure control, the volume will change. So, this is how your volume control and pressure control and SIMV, volume SIMV and pressure SIMV and pressure support work. I hope I am clear regarding this and the basic graphics which are there. Dr. Sreelakshmi had explained the pressure time graph. This is the flow time graph. This is the inspiratory part and this is the expiratory part. And you have to be careful that the expiratory baseline, expiratory flow is touching the baseline. Otherwise, that indicates that your expiration is prolonged. You need to prolong the expiration or decrease the rate so that there is no volume trapping and there is no auto beep generation. Right. So now I'll come to the second part of my lecture. I'll just switch it off. Just give me a minute and I'll come to asynchrony. Now, asynchrony is nothing but we always say that the patient is fighting a ventilator. So basically, asynchrony is nothing but what we call that the ventilator is trying to give a breath, patient is trying to expire. So there is a mismatch between the ventilator and the patient breaths. That is asynchrony in simple terms. So I have no disclosures for this. Some of the images are from Google. So basically, it is a mismatch between patient and ventilator, and delivery of ventilatory support does not match the patient demand. Either the patient demand is high or the ventilatory support is high, and vice versa. So they don't miss and match. So there's a clash and they fight each other, and which causes problems. There are many reasons for that. Now, a classic example is this. Tom and Jerry, we all know. Tom is trying to play the piano to create a tune, and Jerry is creating problems for him. So that is a classical example of asynchrony in ventilation as well. One is the ventilator and one is the patient, and they are not in harmony. So in synchrony, when the patient is not taking a breath, the ventilator gives a breath. And if the patient wants to take a breath, either the control breath is synchronized by the ventilator, or if the patient takes a spontaneous breath, if it's inadequate, the ventilator supports it. So the demand is met and there is no fight between the two. Okay. Now, in passive mechanical ventilation, the problem is we can always paralyze the patient. That's the easiest thing to do. बहुत ज़्यादा fight कर रहा है, just give rocuronium, knock off the patient and take the patient on control. But this has certain problems. We have respiratory muscle atrophy and we might have diaphragmatic dysfunction and difficult weaning over a period of time. So, if we let the patient and ventilator asynchrony continue, then it leads to ineffective ventilation. Naturally, the oxygenation and adequate removal of carbon dioxide is not occurring. There is increased work of breathing and patient obviously is in discomfort. So there are many etiologies for this. This could be because of the flow, that the ventilator is not able to give enough flow to meet the tidal volume, ineffective efforts on the part of the patient. There might be auto-triggering. Triggering is when the ventilator senses that the patient is trying to take a breath, but the ventilator, it's a false alarm. The patient is not taking a breath, but ventilator feels that the patient is taking a breath and I need to support it. Double triggering, we'll just see it. Premature cycling. Now, the patient's inspiration has not completed, but the exhalation valve opens, and because of the positive pressure, the expiration starts early. So naturally, the gas exchange won't be adequate, and delayed cycling. Now, the inspiration has been completed, the patient wants to expire, the intrathoracic pressure has built up, but the exhalation valve does not open. The cycling does not occur, expiration does not occur. So that is delayed cycling. So this is all will occur. Okay, so as I said, the breath is volume or time delivered. Trigger is changeover from expiration to inspiration, and cycling is changeover from inspiration to expiration. These are the terminologies that you have to remember. Now, flow in synchrony is that the ventilator does not give enough volume or the enough flow to peak inspiratory flow to meet the patient demand. So this is normal. If you see here, pressure volume, pressure time graph. If you see here, this is the normal angle. But if the inspiratory flow is not adequate, there will be scalloping of this graph here. So this results in increased work of breathing, dyspnea, increased respiratory drive. So these are the patient risk factors. The ventilator risk factors is this is commonly seen in volume control, inadequate level of assistance, and the rise time, as I said, is inadequate. So you have to set a higher rise time for these patients. So this is flow starvation. That means the flow is not adequate. And then we have volume starvation. That means that the flow is adequate, but the volume that the patient requires is not adequate. So lower part is flow and the upper part is volume. Now, these modern ventilators usually we don't see flow starvation because the flow is decided by the ventilator itself. How much flow to give for a particular tidal volume, depending on the compliance and resistance of the patient. So in this, if this happens, what do? You adjust the flow or flow pattern to match patient demand, or you change over to pressure based mode, and you try and decrease the patient's drive. So if the drive is excessive, you sedate, you give adequate analgesia, and then the synchrony would be there. Now, if the patient's efforts are inadequate, so patient is trying to take a breath. If you see here, patient has taken a breath here, but that is not supported by the ventilator. So patient has taken in a breath, but it is unrecognized by the ventilator. So increased work of breathing. Again, it is because of inadequate pressure or flow to open the valve, inspiratory valve, and the slow response of the valves of ventilator, or it could be because of auto PEEP. So how do we correct it? Now, if you see here, this is a wasted effort. The patient has taken a breath, but it has not been supported either by the controlled breath or by the supported breath. So this again, you can see here is the wasted effort by the patient. Okay. So ineffective patients, so risk factors for the patients, a lot of risk factors, you have to correct these.
Dr. Nishant, sorry to interfere. Whether you are moving any slides or without slides you are taking, because your desktop is visible for the past 5 minutes.
Okay, sir. I think I shared it, sir. I'll just share it
Oh,
again.
that is what I wanted to say. But I thought you were
Okay,
going to
okay,
say
sir.
that.
Okay, sir.
But
No
all
one
the
told me
that is,
actually.
only
No,
your voice is heard.
we thought that you are talking extempore. That's why
No,
nobody
no.
interrupted
Yes.
because you had no
Okay.
slides in the beginning also. So for the
No,
past,
that is
as sir
okay.
said,
I'll
5
just share. I'll just share.
I
Now.
was waiting.
Can you see it now?
Yes.
Yes. Now it is seen.
Okay. Visible, sir?
Yes.
Okay. Yeah, sure. So the ineffective efforts, you want me to repeat any of it, sir? I can repeat it if required.
No, don't repeat because we'll overshoot the time then.
Okay.
Yeah, it's already been quite a lot.
Okay. So the patient risk factors for ineffective efforts are alkalosis, COPD, coma, decreased RAS, that is the patient is depressed, delirium, increased intrinsic respiratory rate, hypercapnia, low minute volume or the low efforts by the patient, age and intrinsic PEEP. So these are the risk factors. The ventilator setting risk factors are airway leaks, delayed cycling, a very high tidal volume, which overshoots the patient demand, a very high pressure support, trigger is very high. That means the you have set it at 4, but the patient will is generating an effort of only 3, and the inspiratory time is very high. So these are the problems with the ventilator. So all we have to do is correct these problems, decrease the trigger, decrease the pressure support, increase flow cycling criteria, and increase the PEEP setting. Auto triggering is when the patient is not generating a breath, but the ventilator feels that the patient is taking a breath. So if we set the trigger sensitivity too low, we have set it at 2, but the patient will trigger the breath at 3 centimeters of water or 3 liters per minute. So the ventilator will feel that the patient is taking a breath, but actually the patient is not taking a breath. This can occur in hiccups, cardiac oscillations, or fluid in the circuit or leaks. So as you can see here, you can see that the ventilator feels that the patient is taking a breath, and it triggers a breath when the patient is not taking. So you decrease the trigger sensitivity and you compensate for any systemic leaks. Double triggering is 2 breaths occurring in less than half of TI. So just 2 breaths, just like a bigemini, the ventilator delivers 2 breaths consecutively. So that means that the patient demand is more than the set TI. That means you causing increased tidal volume and over distension. So what we have to do is, this usually happens in assets controlled ventilation when the tidal volume is too low, pressure support is not adequate, and the inspiratory time is too short. So we have to increase the inspiratory time. We have to increase the inspiratory flow. Tidal volume may have to be increased, and the flow cycling criteria have to be decreased in this particular scenario. Premature cycling happens when the patient is still inspiring, but the ventilator initiates expiration. So again, increased work of breathing. So the neural inspiratory time, the patient's inspiratory time is high, but what we have set is low for the ventilator. Excuse me. This will also lead to reverse triggering. That is, passive ventilator insufflations trigger involuntary patient effort. So it results in diaphragmatic muscle contractions and respiratory muscle contractions as well, maybe due to Herring-Brewer reflex, and the reverse trigger may cause double triggering as well. So if there's a diaphragmatic effort, here it's a diaphragmatic effort, it causes a double triggering. That means that because of the ventilator oscillations, the diaphragmatic contractions are initiated, which are taken as a trigger by the patient, by the ventilator, and a second breath is delivered. So this is the reverse triggering as I've shown. So that means that the patient is too deep. You might have to use NMBAs in this particular condition. You might have to go for support, pressure support, and you might have to increase the rate to prevent this. Delayed cycling, when the ventilator set TI is more than the neural TI. As you can see, here the ventilator is continuing with the inspiration, but the patient wants to expire. Again, increased work of breathing, and this will result in auto PEEP as well. So, because of the leak and the incorrect setting of the ventilator TI, these things happen. So again, this will cause, what will cause, because of the delayed cycling, the expiratory time will decrease the lung apnea, and will cause dynamic hyperinflation or intrinsic PEEP, which it is usually due to trigger delay and trigger workload, and causes increased respiratory muscle workload. So you have to adjust the cycling criteria. Maybe you're giving too much of a pressure support, and the drive has to be adequate for the patient. It should not be too high or too low. So this is just a summary. I'll just rush through it. If the level of assistance is too high, you will cause hyperinflation, increase intrinsic PEEP, increase in ineffective efforts and discomfort. If it is too low, natural tachypnea, discomfort, and hypercapnia. If the trigger sensitivity, that is the threshold for inspiration, is too sensitive, auto-triggering, leading to altered gas exchange. If it is less sensitive, ineffective efforts and increased work of breathing. So why are so worried about asynchrony? Naturally, the respiratory muscle function will increased chances of ventilatory muscle failure, dyspnea, discomfort, and prolonged difficult weaning. There's obviously difficult gas exchange because there's not adequate time for the gases in the lungs for gas exchange. ARDS, we all know we have to have a lung protective ventilation, but this might cause increased tidal volume, increased pressures. It may cause volutrauma and barotrauma. Dyspnea, sleep disruption, increased need for sedation. And we know as we increase the sedation, we increase the duration of mechanical ventilation, hospitalization, ICU length of stay, and mortality. And if the pressure support is too high, increased incidence of ineffective efforts. The patient will not breathe at all. So this is just a flow chart just to say what is the asynchrony, what is the cause, what is the result, and what it will lead to. So this is usually the result of asynchrony. We don't want the patient tired and huffing and puffing. We want a calm and adequately breathing patient whom we can wean off time. Thank you. Thank you so much. I'm sorry for the slides, but I think there was some technical issue with that.
Thank you so much, Nishant. That was very elaborative, and I'm sure everybody who listened to this will benefit. If I can just ask you to summarize, what are the 3 simplest things you can do to prevent this asynchrony? Simplest 3 things.
Simplest 3 things are, number 1, I would say avoid neuromuscular blockade. That is one.
Which is probably the most common thing that is done in patients.
That is done in the ICUs.
Yes,
whenever we have asynchrony, the first response is you give a blocker. No.
So you advise that's not the thing to be done.
That is not the thing to be done. You have to see the patient mechanics and the ventilatory mechanics. The most common cause is inadequate analgesia or sedation. And then...
So a good deep sedation will definitely help.
Yes.
And anything else? 2 more things?
See the graphs and see the TI, what the patient is, when the patient is trying to breathe and when the ventilator is trying to deliver a breath. When the expiration is occurring, when the expiration is not occurring. Whether you're giving too much of support or too much of tidal volume or too
that's okay. What should you do? This you've all explained. 1, you said increase sedation.
Increase sedation.
Next.
Then you have to set your alarm so that you know that there's asynchrony, and then you have to see the patient and the ventilator and adjust the ventilator according to the problem that they are having. So it is...
Call for help.
Call for help. Call the senior. Call the expert.
Call for help.
Call for help. And you just don't go on increasing sedation also, because if you make the patient too deep, that will also result in...
it's as bad as paralyzing.
It is as bad as paralyzing.
Okay. So you really need to know your ventilator well. You need to identify the cause of the asynchrony out of the multiple causes you have identified. If there is a resident and he cannot do it, there is absolutely no harm to ask for help. You can increase the sedation to reduce the asynchrony between the patient and the ventilator. That was wonderful. I would also like you, because it's been a really lengthy and elusive lecture, will you just briefly tell me two important differences for the residents between SIMV and assist control?
Okay.
Just
So,
two differences.
Yeah. So SIMV, as I said, SIMV is, there are two things in SIMV. Now we don't have a plain SIMV. We have an SIMV plus pressure support.
Yes.
Where if the patient takes a breath within the window, expiratory window, which is set by the ventilator, the ventilator gives its said controlled breath before its time to synchronize with the patient's effort. And if the patient is breathing outside the window, we have pressure support to augment the patient's effort.
Agree. That you've already told us.
So in assist control, what happens is that every time the patient triggers a breath, the ventilator senses it is giving a breath. So ventilator will give a controlled breath, and then it will give the next breath immediately after that. So what assist control ventilation does, it ends up hyperventilating ventilating the patient in terms of rate and in terms of volume also. So that is the drawback of assist control ventilation. So, that is the SIMV plus pressure support test.
Right. So assist control can never be a weaning mode.
It cannot be a weaning
Whereas
mode.
SIMV can be the start of weaning.
True.
You have, and these days SIMV is really preferred because it prevents respiratory muscle atrophy, which we know is a very important cause of failure of weaning. So SIMV modes, even set at higher rates, are much preferred as compared to assist control modes if you can manage the asynchrony between the patient and the ventilator.
In fact, asynchrony would be less with SIMV plus pressure support as compared to assist control.
Right. So thank you so much. And now that we have learned how to manage our patients on the ventilator, the most important thing is to take him off the ventilator, which requires as much clinical skill as the starting of the ventilation. In fact, besides the skill, it requires a lot of knowledge and a little bit of, what should I say, it's an art to learn with experience when to wean the patients off the ventilator. So we have Dr. Anshu, an enthusiastic member from the department. She will make a wonderful presentation, I'm sure, on weaning from mechanical ventilation. It looks very simple because if you read from the books, you will just have a few criteria and you think that you can just tick them off in a table and then your patient is ready for mechanical ventilation weaning. But I'm sure Dr. Anshu is going to take you through the nuances of how and when to wean the patient off the mechanical ventilator. Thank you so much for being here, Anshu, and the field is all yours.
Thank you, ma'am. At this outset, I would first like to thank Dr. Ranju Singh, ma'am, Director, Professor, and Head of the Department, Lady Hardinge Medical College, Department of Anesthesia, and Dr. Meenakshi Sundaram, and all the members of ISA Puthukkottai City Branch for giving me this opportunity to speak on such an important topic, weaning from mechanical ventilation. Now, weaning is an important part of mechanical ventilation only. It is a process of withdrawing mechanical ventilatory support and transferring the work of breathing of the patient from ventilator to patient. Now, weaning, it requires a gradual process, though weaning, abrupt termination of support may be possible in a patient who are for the relative short time on ventilatory support, but other patients who have been for a longer period require strategic and continuous monitoring for a successful weaning trial. So what is weaning success? Weaning success is defined as absence of ventilatory support for 48 hours following extubation. And after extubation, even if patient is receiving supplementary oxygen, bronchodilators, positive pressure support, ventilation, or CPAP, then also it is a successful weaning. Now, there is a term called weaning in progress, which is the intermediate category in which it is between weaning success and weaning failure, and patients are extubated, but they continue to receive the non-invasive ventilatory support. And use of NIV allows early weaning attempts and it minimizes the complications associated with prolonged mechanical ventilation and artificial airway. Now, weaning failure is said to be occurring when patient needs re-intubation within 48 hours following extubation or patient does not sustain the spontaneous breathing trial. Weaning becomes more challenging if there are earlier failed attempts. So whenever patient is to be decided for weaning, first the patient has to be assessed properly, and we have to see whether patient has recovered from the acute phase of disease which has led to mechanical ventilation, and is there any adequate spontaneous breathing present. For this, we have to check for the conditions that may hinder the weaning process. Like if there is fever, infection, renal failure, then weaning may be difficult. So we have to correct these things, and we have to ensure the hemodynamic stability by ruling out any variations in blood pressure, cardiac output, presence of arrhythmias, fluid imbalance, or any acid-base electrolyte imbalances, or electrolyte imbalances. Now, there are various weaning criteria which help to assess the readiness of the patient for the weaning, and on which the success trial of the weaning depends. So before we give any weaning trial, we have to ensure that these criteria are met. These includes clinical judgment of the patient, adequacy of the ventilatory criteria, oxygenation criteria. We have to keep in mind that pulmonary reserve is adequate and pulmonary measurements are within normal limits. So coming on to the clinical criteria, first of all, we have to see that there is a resolution of acute phase of the disease. There is adequate cough which is present, and there is absence of excessive secretions which will increase the work of airway and will increase the airway resistance. Then cardiovascular and hemodynamic stability has to be ensured, and ventilatory criteria has to be met, and spontaneous breath is mandatory to be present before we wean off the patient. So ventilatory criteria include excuse me, measuring the arterial carbon dioxide levels, measuring vital capacity, spontaneous tidal volume. Then we have to see the frequency. Then rapid shallow breathing index is one of the important indices. And then we have to see whether minute ventilation is satisfactory. So PaCO2 is one of the reliable indicators of patient ventilatory status. And PaCO2 should be kept between 35 to 45 mmHg, and pH should be between 7.35 to 7.45. And in COPD patients, slightly higher PaCO2 is acceptable and slightly lower pH is acceptable. For vital capacity and spontaneous tidal volume, we have to measure them because they evaluate the mechanical condition of the lungs. And for successful weaning, minimum vital capacity is to be 10 ml per second and spontaneous tidal volume to be 5 ml per second. Now, how do we measure vital capacity and spontaneous tidal volume? Before we measure this, we allow the patient to breathe spontaneously for 3 minutes under close observation prior to measuring these volumes. Now, VC requires patient effort and cooperation because maximum amount of vital capacity includes maximum amount volume that patient can expire following a maximum inspiration. So patient has to be trained and cooperation is required. And for spontaneous frequency, again, we have to follow the same procedure. We leave the patient for 3 minutes on the spontaneous before measuring the spontaneous frequency, and it should be less than 35 per minute, and PaCO2 should be less than 50 mmHg. If it is then greater than 35 per minute, that indicates that there might be rapid shallow breathing, which will increase the dead space ventilation, and there will be ineffective gas exchange. And moderate to significant increase in spontaneous frequency after discontinuation of this mechanical ventilation, it indicates that there might be impending weaning failure. Now, one of the very important index, rapid shallow breathing index, is assessed, which is the frequency divided by the tidal volume of the patient. It reflects the degree of rapid shallow breathing. In patients breathing rapidly with small tidal volume, the index will be increased. And RSBI is affected by the factors like fever, infection. That's why we have to rule out all these factors before giving the trial. So minute ventilation is also one of the important criteria, which should be less than 10 liter per second, and high minute ventilation will lead to increased work of breathing. The causes of increased minute ventilation may be because, because of increased carbon dioxide production due to extensive burns or increased body temperature. Dead space ventilation can also occur, which is due to increased alveolar ventilation more than alveolar perfusion, which will lead to the wasted ventilation. Now, dead space ventilation can be because of overventilated lungs like in emphysema, or because of underperfusion of the pulmonary circulation like in pulmonary embolism and decreased cardiac output. Now, for oxygenation criteria, we have to measure oxygen saturation in blood with PEEP and without PEEP. Then the saturation of the oxygen, which is measured by the pulse oximetry, PaO2 by FiO2, PF by P by F ratio. Then we have to measure the shunt fraction to the total perfusion fraction, and alveolar arterial gradient has to be seen before deciding that oxygen criteria are met. So regarding oxygenation, successful weaning criteria includes PaO2, which is more than 60 mmHg, on FiO2 of less than 0.4 without PEEP, or PaO2 of 100 mmHg with PEEP on FiO2 of less than 0.4. Roughly, the arterial oxygen concentration of 60 mmHg is equal to the saturation of 90%. And patients with anemia or dysfunctional hemoglobins, they do not truly reflect the oxygenation status. And in such patients, we have to measure the arterial oxygen content and arterial oxygen saturation. Now, we have to see the P by F index, which is arterial oxygen tension to the inspired oxygen tension, or which is reflecting the degree of intrapulmonary shunt. It has to be more than 150 mmHg so that acceptable physiological shunt is present and there is a successful weaning trial. Now, we also look for QS by QT ratio, which is a physiological shunt to the total perfusion ratio. It gives an idea about the wasted pulmonary perfusion, and it should be less than 20%. It is because shunted pulmonary perfusion cannot take part in gas exchange, which leads to mismatch of ventilation. It is calculated using end capillary oxygen content and arterial oxygen content difference divided by the end capillary oxygen content and mixed venous oxygen content. Again, alveolar arterial tension gradient is also an important criteria, and it estimates the degree of hypoxemia and degree of physiological shunt. And it is used to if it is value is about 350 mmHg on 100% oxygen, it approximates 14% shunt. And if it is less than 350 mmHg on 100% oxygen, that it indicates that weaning success is likely. Now, pulmonary reserves have to be seen, like vital capacity and maximum inspiratory pressures are measured. Vital capacity reflects the patient's pulmonary reserve, and it includes 3 volumes: inspiratory reserve volume, tidal volume, and expiratory reserve volume. And it is measured by measuring the maximum amount of lung volume that patient can exhale following maximum inspiration. In this, unlike our forced vital capacity, it does not require forceful exhalation. Patient is instructed to breathe in as deeply as possible and exhale all air into the spirometer. And for successful weaning, vital capacity should be greater than 10 ml per kg. Now, maximum inspiratory pressure is the measure of the ventilatory muscle strength, which is very important for weaning of the patient. If strength is adequate, if we can assess that, then success is going to be likely. So patient is it is the amount of negative pressure that patient can generate in 20 seconds against a closed occluded measuring device, which is negative pressure manometer. And weaning success is likely if it is more than of at least minus 30 centimeter of water. And remember that duration of airway occlusion is an important factor in determining the accuracy and reliability. Now we have to see the pulmonary measurements and pulmonary factors also in favor, like static compliance, airway resistance, and VD by VT ratio. So these are not dependent on patient's cooperation or effort, and they indicate the pulmonary workload that is needed to support the spontaneous ventilation. So whenever there is low compliance or high airway resistance or high VD by VT ratio, that means there is increased workload and weaning success is likely to not to be there. Static compliance is measured by dividing the patient's tidal volume by the difference in plateau pressure and PEEP, and lower the compliance, greater the work of breathing, and greater is going to be weaning failure chances. Excuse me. So minimum compliance for successful weaning is to be 30 ml per centimeter of water. Airway resistance, again, very important factor, and it is calculated by dividing the difference in peak inspiratory pressure and plateau pressure by constant inspiratory flows. Its normal range is between 0.6 to 2.4 water per liter per second. And though there is no critical value for airway resistance, but work of breathing is directly related to the degree of airway resistance, and it is increased by bronchospasm, tube resistance, and secretions. So endotracheal tube contributes significantly to airway resistance, and we have to ensure we have to minimize airway resistance by ensuring that endotracheal tube is not kinged or suction catheter of continuous suction system is not protruding into the tube, or patient airway and lungs are suctioned clearly. And there we can use bronchodilators for relieving the bronchospasm if present. Then dead space to tidal volume ratio is to be seen, which indicates the wasted or not being perfused by pulmonary circulation ventilation. Higher the VD by VT ratio, greater is the minute demand. It is again calculated by finding the difference of arterial carbon dioxide tension and the mixed expired carbon dioxide tension, dividing it by the arterial carbon dioxide tension in mmHg. And if VD by V2 ratio is less than 60%, then success is likely to be achieved. Now, for starting the weaning, after we have seen these readiness criteria, we have all these criteria are met, we give a spontaneous breathing trial. And it is a major trial to determine if patient can be successfully extubated and weaned from the mechanical ventilation. So in this trial, what we do is that we give it for 30 minutes and patient is disconnected from ventilator, and we use a device such as TPs, or we can also do it on invasive ventilator where patient is put on spontaneous modes like CPAP and minimum ventilatory support like PEEP of 5 centimeter of water and pressure support of less than 7 centimeter of water. Whenever spontaneous breathing trial with pressure support ventilation is given, we start at the level of between 5 to 15, so that we achieve a spontaneous tidal volume, which is desired tidal volume between 10 to 15 ml per kg, and frequency is less than 25 per minute. Excuse me. So we titrate it gradually, and it may take from days to weeks to titrate it to the minimum level of pressure support, which is 3 to 6 centimeter of water. And we have to also achieve the minimum PEEP before we try weaning and extubating the patient. SIMV mode can also be used for weaning, and we have to reduce the frequency by 1 to 3 breaths per minute, and gradually over the days, then after a considerable time, we reduce the frequency until it is 2 to 4 per minute. And that we subsequently, we also monitor SpO2 and ABG. And if patient tolerates this reduction in the frequency, then we consider extubation along with the ABG and satisfactory vital signs. So whenever we give spontaneous breathing trial, we have given using either TPs or the spontaneous modes of ventilation. After that, we assess every time the patient. And the criteria for assessment includes clinical criteria, like we assess that whether there is normal respiratory pattern or there is some shallow breathing is not there. There is adequate gas exchange. Hemodynamically, patient is stable. And for all this, we use some criteria which I'll be discussing, like rapid shallow breathing index, serial RSBI, rapid shallow breathing index, rate crop index, express index, and spontaneous weaning indexes. And if patient tolerates we consider extubation when vital signs and ABG values are sufficient, and we return to If it is not, then we return the patient to mechanical ventilation and we try later. So rapid shallow breathing index is the estimate of the rapid shallow breathing of the patient, and it evaluates the effective spontaneous breathing pattern. If rapid shallow breathing is there, we calculate the index by dividing the frequency, the number of breaths, by the tidal volume in liters. And it is measured by the same criteria. We take off the patient from the ventilator and observe spontaneously for 3 minutes until a stable breathing pattern is obtained. Absence of rapid shallow breathing is there, and if the F by VT ratio is less than 105 per breath per minute per liter, it is the accurate predictor of weaning success. Now, if RSBI is used, then it may not be consistent at the starting of the SBT trial and at the end of the spontaneous breathing trial. So it is recommended that serial RSBI is measured, where one value is taken at the starting of the trial and one is taken at the end of the breathing trial. And we see the serial values so that we exclude the index, which is if there is any rapid shallow breathing. Also, one of the very important indexes, RSBI rate. We can see the rate of the rapid shallow breathing index, which is more predictive of weaning success, and it is defined as rapid shallow breathing index over time. Excuse me. And if it is less than 20%, it indicates a weaning success. Then there is the CROP index, which combines compliance, respiratory rate, oxygenation, maximum inspiratory pressure to predict the successful weaning. And if it is more than 13, then it is a good predictor of successful weaning. Then there is another index, Express index, which combines rapid shallow breathing during spontaneous breathing trial, dynamic lung compliance, duration of mechanical ventilation, muscle strength, Glasgow Coma score, and hematocrit and serum creatinine also. So it takes into consideration respiratory and non-respiratory parameters. Excuse me. Patient with score greater than 59 are extubated, and those less than 44 are continued on mechanical ventilation, and those between 45 to 58 with no risk factors are for extubation are extubated, while those with risk factors are extubated on non-invasive ventilation. It's a more robust criteria and leaves many factors in consideration. And there is another Wien-Snow score, which has been recently given by Lin et al. In 2020, which includes endotracheal tube resistance, ABG analysis, nutrition, secretions, neuromuscular affecting agents, and obstructive airway problems and wakefulness into the consideration. And Wien-Snow score of 1 or more needs indicates that there is a need for prolonged ventilation and it is associated with failure of weaning. It is a more complex score, and its application may also be complex. So when do we say that there is a failure of spontaneous breathing trial? Whenever there is a spontaneous breathing trial failure, we will see that the patient is agitated, anxious, having tachypnea, there is use of accessory muscles, diminished mental status, diaphoresis, there may be increased work of breathing also. And there is no difference in weaning trial on TPs or on pressure support or CPAP. Which mode we are using does not make any difference. And if there is a failure of the spontaneous breathing trial within 20 to 30 minutes, then there is no need for using an extended spontaneous breathing trial. And for weaning failure, we keep we assess the certain parameters, like we do the arterial blood gases and see whether there is increase in PaCO2, decrease in pH, decreasing PO2 less than 60 mmHg, decrease in the saturation of less than 90%. Then we look for the stability of the vital signs like changing blood pressure or increasing heart rate, or respiratory parameters have to be looked after, that there is decrease in tidal volume, increase in frequency, or decrease in maximum inspiratory pressure. All these things we have to keep in mind when we decide that it's a weaning failure. So weaning failure can be due to the increased airway flow resistance, decrease of compliance, or respiratory muscle fatigue. Increased airway flow resistance is an important factor which sometimes leads to the failure of spontaneous breathing trials. Excuse me. Endotracheal tube, it increases the work of breathing depending on the size. So size is very important. And usually it is seen that 8 mm endotracheal tube has cross-sectional area of 50 mm square, which is smaller than the cross-sectional area of adult glottis, which is 66 mm square, which is the narrow at the glottis, which is the narrowest part of the airway. So we should try to use endotracheal tube of size greater than 8 whenever possible. We can cut the length of the tube to decrease the resistance and prevent the tube kinking or obstruction due to secretions or presence of HME filters. And we can use bronchodilators if there is any bronchospasm. Then we have to keep in mind that certain factors which can decrease the compliance, like atelectasis, ARDS, tension, pneumothorax, all can decrease the static compliance, or there can be decrease in dynamic compliance by the factors which have discussed. We have discussed like bronchospasm, kinking of tube, airway obstruction, or retained secretions in the airway. Also, there can be a respiratory muscle fatigue, so which will increase the work of breathing. So it is important that we have to monitor that there is no respiratory muscle fatigue. And for all this, for respiratory muscle fatigue and evaluating all this, we can use now newer modalities like ultrasound. Ultrasound assesses the diaphragm, and we know that diaphragm is the primary inspiratory muscle involved in breathing. And mechanical ventilation leads to diaphragmatic atrophy and dysfunction. So ultrasound can be used to measure the diaphragm thickness and diaphragmatic excursion and many other factors to rule out that there will be no weaning failure after we have given the trial. And it also assesses the critical conditions like hypotension, hypoxia, infections, which can also hamper the weaning of the patient. So there is a ABCD protocol which can be used by using ultrasound, where we assess the aeration score and pulmonary effusion. So patient is the chest of the patient is divided into 6 zones on the right and 6 on the left by the line left by the parasternal line, anterior axillary line, and posterior axillary line. And there is a line below the nipple, so it divides the chest into 4 zones anteriorly and 2 zones posteriorly. So we assess the aeration score, where there is a 0 point if only A lines, which are the horizontal lines which are normal, are present. Then 1 point is given if there are B lines, which are the longitudinal lines. If they are 3 or less, then it is 1 point, and they are not confluent. When they are slightly confluent, less than 7 mm distance, then we give 2 points, and 3 points when there is a consolidation. So lowest score is 0, which indicates normal aeration, and highest score is 36. And patient's weaning success depends on the lung score of the patient. Also, whenever there is increase in B lines more than 5, it is associated with extubation failure. Now, A was for aeration, B is below the diaphragm. We also assess that there is no abdominal fluid connection or any abdominal pathology which is occurring. Excuse me, because increased abdominal pressure can affect respiratory mechanics and weaning. So we can rule out the presence of free fluid between the spleen and kidney and any peritoneal fluid or collections. Then cardiac assessment can also be quickly done in many views, and it will assess about the regional wall motion abnormalities, stenosis, regurgitation of cardiac walls, etc. So that if there are no problems regarding the vitals and the clinical condition of the patient, and we can quickly have a look at the cardiac role also. It is especially important where we have faced a weaning failure. We can, next time when we give a trial, we can do a cardiac assessment. Then diaphragmatic assessment is very important through ultrasound, and it excludes the diaphragm dysfunction as a contributor to weaning failure. Diaphragmatic excursion is measured by a subcostal approach where the probe is kept between the anterior axillary line and the mid-axillary line in the subcostal region. Diaphragm excursion is basically the movement of the diaphragm. And here we can see we keep the probe in the subcostal region. This is the diaphragm. This is the liver. And when this is in the B mode, and then when we put the ultrasound in the M mode, which is the motion mode, we get this waveform kind of a pattern, which is the inspiratory cycle. So we get this pattern. This is the inspiratory slope. So we measure we keep the caliper at the lower and the upper point of the inspiratory slope of the diaphragm, and we measure the excursion, which should be less than 20 mm Hg. And less than 10 to 15 mm is associated with weaning failure. So this is the diaphragm excursion we measure. Then we can also measure the diaphragm thickness, which gives an estimate about the diaphragmatic contractility. It helps to assess about the atrophy of the diaphragm. If thickness is decreased, then it indicates the atrophy. And if it is increased, then it may be a warning sign against the edema and fibrosis which may be present. Normally, the diaphragmatic thickness should be less than 30 to 35%, and diaphragm excursion should be less than 10 to 15 mm. So in this, we place the probe in the 8th to 9th intercostal space at the between the anterior and posterior axillary line to end the zone of apposition. Zone of the apposition is a place where the diaphragm meets the thoracic cage. So we place the probe, and here we can see when we have placed the probe, we first saw the B mode where we can see this is the diaphragm, and then we place it in the M mode, which is the motion mode, and we look for the inspiratory and the expiratory phase. So diaphragm is thickest in the inspiratory phase. This is the inspirate, and this is the thickness at the maximum inspiratory phase, and this is at the end of the expiratory phase. So we calculate the diaphragmatic thickness fraction, which is the difference of thickness at the end of maximum inspiration and the thickness at the end of expiration, and we divided by the thickness at the end of the expiration multiplied by 100, which gives the predictive value of weaning failure if it is between less than 30 to 35%. Then there are other modalities using ultrasound like tissue Doppler imaging and tissue. So in this technique, we detect the alteration in frequency of ultrasound signals reflected by mobile structures, and it has been also used extensively, and it is a more recent development. Then there is a speckle tracking using ultrasound, in which it is also known as strain imaging, which involves tracking ultrasound speckles over time. These speckles represent the regions of muscle tissue with stable gray patterns in ultrasound imaging. And STUS software works by tracking a group of speckles throughout contractile cycle and measuring their displacement and deformation in relation to each other. STUS offers advantage over the thickness fraction, that it is unaffected by angle between ultrasound beam and tissue motion fraction. Then there is a shear wave elastography, which is innovative technique and has been recently developed. It measures the shear wave which is produced by inducing tissue deformation through generation of focused acoustic impulse beam by ultrasound probe. And higher the shear modulus, higher will be the tissue stiffness. This is a new technique to gauge diaphragmatic effort. And last but not the least, it is important to assess the extra diaphragmatic muscles also, because expiratory muscle atrophy, which impairs the airway clearance, may lead to extubation failure during the despite passing of the spontaneous breathing trial. And we assess the extra diaphragmatic muscles by starting with the parasternal intercostal muscle, followed by rectus abdominis, internal oblique, external oblique, and external oblique, internal oblique, and transversus abdominis, with the same window where they appear as parallel layers. So I would like to summarize by saying all patients receiving ventilatory support should be assessed on daily basis for their suitability for weaning, and it may require meeting several preconditions and spontaneous breathing trial success. If unsuccessful, weaning should be attempted using either pressure support ventilation or daily spontaneous breathing periods of increasing duration. Ultrasound is readily accessible, non-invasive imaging modality, then can be used in bedside weaning assessments, and though it shows promise, but it needs further high quality research for its role in weaning process. Thank you for the patient listening.
Thank you very much, Anshu. That was very exhaustive and covered all aspects of weaning so well. I'm sure the postgraduates listening in will definitely benefit from this comprehensive review of weaning from mechanical ventilation. What I would just like to ask you very simply is, what are the commonest factors in your experience which cause failure of spontaneous breathing trial clinically?
Ma'am, spontaneous breathing, the commonest factors are like when the spontaneous efforts are not adequate, or sometimes it is seen that patient is on the has endotracheal tube in place, but it is not it is not patent. There might be some suction, there might be some secretions or clots which are hampering the breathing the success of the breathing trial. So we have to ensure that the airway on which we are trying the trial should be patent. At least when we are putting the patient on TPs, it should be patent airway, proper suctioning has been done before, and we have given the adequate time for the patient to equilibrate to recover from the clinical condition which patient is suffering.
Right.
When that is treated adequately, when all the hemodynamics are within normal limit, patient is off the inodrops and hemodynamic stability is ensured, then definitely patient has the strength to breathe on its own, and weaning is a success.
Right. So from this, what I gather is that the extrapulmonary reasons or the extrapulmonary parameters are probably more important than this slew of ventilatory parameters which are usually highlighted.
Yes,
You have tables and tables of ventilatory criteria and oxygenation criteria and vital capacity and so many other things where you just miss out on the basics of patient management.
Yes,
Have a look at your patient, see whether he's recovering well, see whether he's nutritionally doing well,
yes,
whether his protein levels are good, his temperature is controlled, he's hemodynamically stable, orientation and cognition is good, he's able to follow commands, muscle strength is good. All these parameters are just as important as merely seeing oxygenation and ventilation criteria.
yes, ma'am.
So I think this is a very important message which everybody listening to this webinar must take in. Okay, and you've also highlighted so many scores for checking whether the patient is fit for ventilation. Do you think combining scores helps, or is there a single comprehensive score which will help?
Ma'am, actually there is no single comprehensive score. We can choose some simple scores like rapid shallow breathing index, which is easy to assess. And if we find that it is a complex weaning, then we grow gradually over. We pick a simple index and we gradually go over that index instead of falling into 42 parameters or 55 parameters, which are not practically possible to follow.
Yes, it sounds very nice when you're writing a theory paper, but practical experience has taught me that if you keep it simple, you will succeed more. So like the airway assessment, similarly assessment for weaning failure, if you keep it really simple, you'll be able to monitor the progress better. So probably a simple, looking at the non-pulmonary criteria, then rapid shallow breathing index, and now, as you beautifully illustrated, the use of ultrasound to see diaphragmatic activity will, in combination, probably keep it simple also and provide a comprehensive evaluation of whether the patient is ready for weaning or not. So you've also said that spontaneous breathing trials and probably SIMV and pressure support are modes which are used commonly for weaning. Other than this, do you think are there any other modes which can be used for weaning?
Yes, ma'am. Actually, we can use the minimum mandatory minute ventilation mode
Okay.
and APRV, adjusted pressure release ventilation modes, also for weaning, in which we adjust the pressures and we put the patient on minimum pressure and minimum PEEP, and we can do weaning on these modes as well, on the higher modes of ventilation, by gradually bringing them to the minimum basic levels.
Okay. So thank you so much for that, Anshu. It's been a very comprehensive analysis of the entire mechanical ventilation continuum, from the basics of the ventilator to the ventilatory mode.